Good afternoon all. After that very wonderfully presented argument, I'd like to come straight to the point. Hypothyroidism in pregnancy, are we over-treating? Absolutely not, and we will see why. So ATA, the Thyroid Association guidelines recommend verbal and clinical screening. So testing all may not be cost effective, they say, but screening in high risk women. But what are we actually doing in our hospitals? We end up screening every pregnant woman. Does any obstetrician have the courage to go ahead without screening? So we are not actually blindly following guidelines here. How are we currently treating hypothyroidism? I won't go into the details because that's already been wonderfully elaborated by Dr. Akila. Overt hypothyroidism treat, subclinical hypothyroidism treat, no ambiguity there. TSH 2.5 to 4 we test and we can consider treating. So nobody is saying you must treat, we can consider treating. Okay. So what are the effects of not treating? They are really bad, they can be really dangerous. Most study results show that greater improvement is there when thyroid replacement is initiated earlier in pregnancy. Untreated hypothyroidism may result in preeclampsia, preterm delivery, gestational hypertension, postpartum hemorrhage, low birth weight in the baby, neuropsychological and cognitive impairment in the fetus, and increased perinatal mortality and morbidity. So this is not exactly hypothyroidism in the mother and the baby was born, but I am just putting a picture just last week what I saw, untreated hypothyroidism in the baby, okay, years ago, which led to a low IQ, which is a nightmare for treating physicians and endocrinologists. So we don't want low IQs, however mild the effect may be on the baby. So the fetal thyroid, the development starts and around week 8 and the development happens, and then the fully functioning thyroid is only at 18 to 20 weeks of pregnancy. Until then it is totally dependent on the mother for placental transfer, and thyroxine is also required for adequate placentation. That is why the risk of early pregnancy loss, which is pregnancy loss below 20 weeks of gestation. So what is the evidence for treating? So what they say is it is deemed unethical to perform randomized control trials for overt hypothyroidism where the comparator is placebo or no treatment. So the limited available RCT evidence has focused on dosing regimens only. So no one has the guts to not treat, first of all. So it is deemed, it is declared like this. For answers to other clinically relevant questions, we rely only on observational data. So it is always better to be safe than sorry. So this is one of the earliest evidences published in NEGM in 1999, where the thyrotropin, that is TSH, was measured in stored serum samples collected out of 25,000 pregnant women between 1987 and 1990, and later the 7 to 9-year-old children who were born were checked and they underwent 15 tests of IQ. So what they found was the IQ scores were 4% lower in the 62 hypothyroid mothers, and of the 62, 48 were not treated during pregnancy. So the full IQ scores of those children averaged 7 points lower. So what are we doing to these kids? So what are we achieving by not treating them? So here is another piece of evidence. It's a systematic review and meta-analysis which included cases of pregnant women with TSH more than 2.5 and 3 in the first and second and third trimester respectively with positive anti-TPO, and it included data from 2,873 pregnant women. Incidences of preterm birth, abortion, postpartum hemorrhage and low birth weight infants in pregnant women treated with levothyroxine were lower than those in controls. So huge piece of data. Unlike the data shown by Dr. Akila, Indian data 2 or 3 studies of 100 studies, 100 patients, 96 women, that's all. So this is huge piece of data that we have. Here is another study, a totally different perspective if you look at. A prospective study on 74 pregnant hypothyroid women. What they found that there was cardiac remodeling and systolic diastolic functional alterations in the fetuses. Okay, keep the brain aside, what about the heart? So it is showing that it can have effect on the heart of the babies as well. We may not even realize it until they reach much older, adulthood or older childhood. This is another study of 1671 pregnant women where subclinical hypothyroidism was considered with TSH 2.5 to 10, and 675 in the screening group had out of them 167 had subclinical hypothyroidism, 996 in the control group, 252 had, and the risk of miscarriage and fetal macrosomia was higher in the control group, risk of cesarean was higher in the screening group. These were all clinically significant. This is another data, I won't go into the details, but 3,315 pregnant women. So, isolated thyroid autoimmunity with normal TSH level was associated with higher risk of miscarriage. So, we all know what miscarriage causes to the mother and to the entire family, very devastating, better to treat. When both thyroid autoimmunity and subclinical hypothyroidism coexisted, the risk of miscarriage increased significantly. But even when euthyroid, the risk was always there according to this data. So, what they postulated was there must be an additive or synergistic phenomenon of thyroid autoimmunity and subclinical hypothyroidism that is postulated. Okay, let us look at only thyroid autoimmunity and pregnancy, because the guidelines keep saying test for antibodies. Okay, consider testing. The prevalence of anti-TPO positivity is higher in women with subfertility and a history of recurrent miscarriage compared to general population. It is 17 to 33% versus 6 to 20%. Risk of early miscarriage is substantially raised with the presence of thyroid autoimmunity even in euthyroid state. Quantitative and qualitative changes in the profile of endometrial T cells with changes in cytokine secretion such as reduced secretion of interleukin 4 and interleukin 10 along with hypersecretion of interferon gamma can hamper successful pregnancy. These are all recent data. So, why consider treating when euthyroid? Despite what they say, despite biochemical euthyroidism, thyroid autoimmunity could be associated with a subtle deficiency in thyroid hormones. We may not see, but there must be a subtle. Plus, we also know that pregnancy increases the demand for thyroid hormone. With an inadequate response of thyroid to adapt itself to the changes related to situations involving increased estrogen levels such as ovarian hyperstimulation or in pregnancy. So, what is the clinical evidence? We have certain important evidence in this. Glenoer performed a prospective study of 87 euthyroid women, that is TSH below 4, who are positive for TPO thyroglobulin antibody or both. 20% of women in this study developed a serum TSH on follow-up. So, at the beginning it was not high, but only in the women later on in the mid or later part of pregnancy they found the TSH was actually went up higher. So, there must be an underlying hypothyroidism there. So, another data is published in the JCM by Negro et al. In TPO positive euthyroid women, TSH levels increase as gestation progressed from a mean of 1.7 to 3.5 with 19% of women having a supranormal TSH at delivery. So, what the guidelines say is be cautious when TPO is positive, monitor frequently and watch. Another study of 11,387 pregnant women where anti-TPO positivity among subclinical hypothyroid patients increased risk of impaired glucose tolerance. So, a third concept comes here. This needs more data, but then it is leading to increased impaired glucose tolerance. So, again we are back to the guidelines. So, in guidelines we know euthyroid pregnant women who are TPO or TG antibody positive should have measurement of serum TSH performed at the time of pregnancy confirmation and every 4 weeks through mid pregnancy, and it demonstrated patients for TPO antibodies demonstrated a 2-fold increase in the risk of pregnancy loss. That is the basis for this. What about the Indian Thyroid Society guidelines? So, this is consensus statement. The Indian study, the Indian perspective, it was not even based on certain original data, but this is a consensus statement by the Indian Thyroid Association by a group of experts. So, it shows that it is very much in line with the international guidelines and it is a regional approach. It follows similar to the ATA guidelines. So, what about the summary of what all we are treating? When we talk of hypothyroidism in pregnancy, we talk of 2 lives, not 1. Cost effectiveness has been tested by authors such as Maraca, where it is cost effective to treat compared to treating complications of not treating, which may be devastating. There is a burden on the patient of not treating and ending up in complications, but the pill burden is hardly anything, hardly any side effects. Over-treating carries minimal risk because mild hyperthyroidism in pregnancy is usually left untreated. Just being a devil's advocate here, let's look at the studies, that is the CAT study, which is often quoted saying probably we are over-treating. Although no differences were found in the IQs of babies in both the groups, the study was not powered to test the same. A key limitation of this study and a few other available high quality so-called studies is the late gestation of treatment initiation. Treatment was initiated much later, so maybe it didn't show benefit in IQ. So it was comparable in the treated group and the control group. Had they started treatment much earlier, so it was all after 8 weeks, 12 weeks like that. It is likely that thyroxine started pre-conception or caught early in pregnancy would maximize the clinical benefit, particularly when assessing early miscarriages and fetal brain development. This is another study what was mentioned by Dr. Akila, where it published in NEGM in 2017, where again it shows between 8 and 20 weeks it did not result in significant improvement in the cognition, but again it was at 8 weeks, not much earlier, not immediately, probably at 6 weeks or earlier. If it was treated, it would have been different. So a major limitation is treatment was started after 8 weeks of gestation. And what are the risks of treating thyroxine, over treating? So we always use the lowest possible dose of antithyroid drugs in hyperthyroidism in pregnancy. Why? Because subclinical hyperthyroidism is often left untreated and observed with monitoring thyroid function test every 4 weeks in pregnancy. We hardly treat. If only TSH is suppressed in, for example, Graves' disease, and FT4 is normal or total T4, T3 are normal, we just leave it like that. So extrapolating this to hypothyroidism, over treating hypothyroidism in pregnancy would hardly negatively impact the fetus and the mother. So my closing arguments here. There is substantial evidence that untreated hypothyroidism during pregnancy is associated with adverse outcomes for both the mother and the fetus. The risk of overtreatment is minimal compared to the high risk of undertreatment. Until proven otherwise, the precautionary principle supports treatment with proper diagnosis, regular monitoring and evidence-backed TSH thresholds. Current treatment protocols are appropriate, protective and far from excessive. Thank you.
Yeah, I congratulate both the speakers on an aggressive stance on, but as we know that we are all panicky, but making patients more panicky is not the frame of mind should be. The guidelines today, whether it is pregnancy or anywhere, the guidelines are making, especially pregnancy being a very sensitive matter where 2 lives are there and the gynecologist wouldn't like to take a chance. The guidelines puts gynecologists at more and more stress. If you put tomorrow at 2.5, the gynecologists are always, so normally a 2.5. So I am a little old timer and I am guidelines based. I do agree, but I take a full point to the second speaker also, where treating aggressively makes a difference, but all the guidelines, if you see, the miscarriage, the higher death, higher baby loss, all complications put together tells that the mother is unhealthy. That doesn't tell pushing them with the medicine will make it healthy is not there for 2.5 to 4. It is there for everything after that. So a sub-analysis of 2.5 to 4 to treat is very important. So even when they take this subclinical, they have taken from 2.5 to 10. Now you have, we all know that nobody dares to tell 4 to 10 don't treat. That 2.5 to 4 treat becomes little tricky. Anyway, I congratulate two pretty ladies for fighting it out and congratulate both for a good presentation. Thank you.
Thank you, sir. With this, we conclude our talk. We thank our chairperson, Dr. Muralidhar sir, and our dynamic speakers, Dr. Akila and Dr. Sowrabha, on the debate. With this, we conclude all the sessions for today. Thank you, everyone, for active participation.